This is a recording from the University of Virginia and the More Than the Score lecture series, made possible by the university's Office of Engagement. Health transcends all geographic, cultural, religious, and economic barriers, and is perhaps one of our most universal and unassailable human values. Rebecca Dillingham is an expert in tropical infectious diseases and a leader in UVA's pioneering Trans-University Center for Global Health. On October 24, 2009, Dillingham presented an overview of UVA's pioneering role in making medical care available to the poorest of the poor across the world. She's introduced by Tom Folders, president of the UVA Alumni Association.
I have the honor and actually very great privilege to introduce Rebecca Dillingham. She's the assistant professor in the Division of Infectious Diseases and International Health and in the Public Health Sciences at the University of Virginia. Dr. Dillingham received her BA from Harvard-Radcliffe College and then traveled to the Ivory Coast, or Côte d'Ivoire, where she lived and worked on HIV prevention for 2 years prior to entering medical school at the University of Missouri, Columbia. Dr. Dillingham served as a resident in the internal medicine and as a fellow in infectious diseases in the UVA health system. She completed her master's in public health at UVA and then joined the faculty in 2006. Her major clinical activity is the care of adult patients infected with HIV. Dr. Dillingham's research projects include the development of improved nutritional approaches for patients infected with HIV and living in resource-poor countries, the use of cell phone-based technology to help vulnerable populations improve adherence to antiretrovirals, I practiced that word, and the evaluation of impact on changes in water and sanitation on the incidence of waterborne disease. This research takes place in Haiti, rural Virginia, and South Africa, respectively. She has also led the development of global health curriculum across the grounds through the National Institute of Health's Framework Program of Global Health. So, once again, please welcome Rebecca Dillingham.
So good morning, and thank you all for being here on this rainy morning. And I really apologize for sitting down, and I may be a little bit fidgety, but I think I'll do better sitting down. So I'm really excited to share some reflections this morning on the tradition of leadership that UVA has in global health. Global health has been pretty trendy. I think we see it in the news a lot, particularly in the last few years, particularly with the increased funding from organizations like the Bill and Melinda Gates Foundation. And some of us may not know that UVA has really been involved in what is now called global health for decades and has really been a leader. And I'm really proud of that. And in fact, it's what brought me here to Charlottesville in 1999, was having spoken to Dr. Richard Garant, who is sorry that he can't give this talk today. He's actually the director of the Center for Global Health, and I'm delighted to get to stand in for him because I'll get to brag about him a little bit more than he probably would. So in any case, during this talk, I will be reflecting a little bit on some of the context that has made global health such a trend, so visible in, say, the past 5 to 10 years. And then I'd like to talk a little bit about why it's important for universities to be involved and how proud I am that the University of Virginia is so involved. And finally, give you some specific examples of the way University of Virginia has involved its faculty, its students, its collaborators, its community in addressing the very, very grave challenges that we face in global health. So I did already receive one group of questions from the audience. I'm going to address some of it during my talk. I'm happy also we're going to leave plenty of time for questions at the end. But if you have something that's really burning during the talk, please go ahead and raise your hand. Okay, so probably we did turn it off. That's right, to save the battery. Probably the global health/global disease issue that we're all thinking about most right now is the H1N1 epidemic, the swine origin flu. And certainly one could define global health in terms of global disease. When you look at a map like this that shows how vast this epidemic is, and particularly how concentrated it is in North America, we understand that disease, particularly acute infectious airborne disease, is quite humbling in terms of letting us know that the diseases of of others are also our own. They spread rapidly. Certainly, the experience of the world population with SARS and with preparation for avian flu has led scientists, communities, public health professionals, all of us as individuals to think carefully about improving our ability to communicate, to stay aware, to protect ourselves, to protect others from disease. So airborne disease is one way of thinking about it, and it certainly brings it very close to home when you go from a map like this to the quite alarming curve here and over the last few weeks of the H1N1 isolates in our region. However, I think that when we really start thinking about global health rather than global disease, there's another disease that serves as a better paradigm, and that's HIV/AIDS. I'm not diminishing the importance of epidemic flu, certainly. It's causing a great deal of suffering right now. But HIV/AIDS is an infectious disease, as we all know, that is a chronic disease that requires even more complex interventions to be able to manage it, because once people are infected with HIV, hopefully they will have many years of life, but in order for them to have many years of life, they need to receive medicines, they need to receive primary health care, and as you can see, and I'm sure as most of you know, the epidemic is focused in sub-Saharan Africa, where access to medicines, access to health care is very limited. So thinking carefully about how we as a global community, how and whether we as a global community should participate in the delivery of care to people infected with HIV has really, I will argue over the next few slides, changed the way we think about global health. I imagine that most of you have seen maps like this before, and I personally find some of the numbers sort of mind-numbing. It's hard to get your head around over 2.5 million new infections each year. I think that it's humbling and important for us all to realize that there's still 56,000 new infections in the United States each year, and that unfortunately that number hasn't changed in a decade. So we're not doing a great job either of preventing the spread of this disease. But in order to really get a feel for this disease, I think it's important to meet the people who have suffered most. This is an incredibly courageous man. I've had the privilege of meeting. I hope some of you may have seen his picture before. His name is Joseph Jeune, and he's from the Central Plateau of Haiti, which is a very rural, very poor part of the poorest country in the Western Hemisphere. He's here in this picture being, he's been brought to the hospital of Zami La Santé, which is the partner in Haiti of Partners in Health, the group co-founded by Paul Farmer. And he's very upset because he feels that the money that was spent to bring him to the hospital would have been better spent on building him a coffin. Because he can't imagine that he's going to get better. He's suffering from HIV and from tuberculosis, and when I use these pictures for trainings in Haiti or in Southern Africa, when I ask the healthcare providers what's going to happen to this man, and even if I ask healthcare providers in this country what's going to happen to this man, what do you think they say? He's going to die. Yeah. And I think that, how many of you have read Paul Farmer's work or read the book about Paul Farmer? Imagine a fair number of you in the audience. So Paul Farmer is somebody, let's take a step back. At Harvard, I was a history major, and I know that there, for any historians in the audience, there's certainly arguments about whether it's great people. Usually we talk about the great men, but great people that really make changes in the world, or whether it's larger social movements. And I think it's both. But I think that Paul Farmer is really one of the great people who has said to us in the United States and to others around the world that we can't afford to look away from the Joseph Jeunes. We can't afford to look at him and say, let's triage him. He's going to die. We have to look at him. We have to think about him. We have to work to help make him better, to deliver a complex health intervention. And we also have to look beyond him to say, what is it that allowed him to get to this state? why is it that he can't find work in the Central Plateau? Why is it that the Central Plateau is so deforested that there is no possibility of growing crops? How is it that he has better access to a coffin maker than to a physician? And I think that because Paul has asked those questions, he was able to work on the individual level to bring Joseph back to health. This is Joseph about 6 months later after he had received treatment for tuberculosis and HIV. And this, I love that gasp that always comes when people see this. Everybody, and I tell you, the physicians in our hospital system also can't believe it, because we would probably also have recommended a hospice consult for this young man. But the fact of the matter is that HIV and tuberculosis are treatable diseases, even in settings like Haiti. And beginning in the late 90s, Paul Farmer and his group worked on this. Others did as well, the World Health Organization, Médecins Sans Frontières. And I'm very proud to say that now about 4 million people in resource-limited settings are receiving antiretroviral care. Antiretroviral care is not as complicated as it used to be. In the early days, many of you may remember, when we first had medication beginning in the late 80s and early 90s, it was 20 to 40 pills a day, very strict regimens that had to be managed in regards to food and sleep, and it was a mess, and they had horrible side effects. Now we can actually treat people with 1 pill once a day, which is far easier. But as any of you know who take medications every day, even 1 pill once a day, if you're looking at taking it for the next 50 years of your life, is a big deal. You need to see the doctor every few months to check for safety labs. You need to be able to have a prescription that you can get refilled. So it's still a complex intervention and an incredible accomplishment. And I would argue that as a nation, as a world, making the commitment to treat these people has really changed the way we view global health, and has challenged us to not look only at the medical necessity of, okay, well, how does the medication work? How does it kill HIV? But also, how do we get the medication to people? How do we prevent the spread of disease? How do we find people jobs again? As you can imagine, Joseph, when he looked like that, wasn't doing much work. Now he actually has a great job. He goes all over the world advocating for people living with HIV/AIDS, and Paul Farmer likes to joke that he's gone from looking like Skeletor to looking like he needs Lipitor. So he's gotten quite hefty, actually, but he's doing very well, and reintegrating the millions of people that were facing death and orphaning their families and leaving their farms. Reintegrating them back into a community is a very important challenge that I didn't learn about in medical school. Finding ways to build them houses when they lost their homes is not something that I learned about in medical school. This is far more complex than just one simple management question about a particular global disease. And fortunately, Paul Farmer is not alone, and nor am I, nor any of us. And we've had some important advocates, including this recent visitor to Charlottesville, who advocated with the late Senator Jesse Helms to George W. Bush about creating the PEPFAR program. And one of the questions on this sheet is, where are some of these medications coming from to treat HIV? And in the clinics that I work in, the medications come either from the World Health Organization's program, the Global Fund, or from PEPFAR, which is the President's Emergency Plan for AIDS Relief. So these are a couple of ways. And as you can see, the quote that Bono used to talk to George W. Bush is one that I think resonates with many of us, and speaks to the reasons people have decided to become involved in global health. Other people have made different arguments. There's certainly religious, moral, value centered reasons that we might become involved in global health. There's the human compassion of seeing someone like Joseph Jeune, but there are also economists, including another recent visitor to Charlottesville, Muhammad Yunus, who won the Nobel Peace Prize in 2006 for his work on microfinance, and the man who wrote this book visited UVA last year, The End of Poverty, Jeffrey Sachs. People have made the argument that it's important economically for all of us to think about global health, because losing millions of people to HIV or to malaria or to tuberculosis impacts all of us in terms of diminishing our markets, destabilizing economies, etc. And so health underlies all of that, and we need to become involved as a society and global health in order to positively impact the economic development worldwide as well. Others have argued that it threatens our very security. The CIA actually in the early 90s was the first to really sound the alarm about HIV in Africa. I don't know if you remember, but President Bill Clinton in the early 90s was not interested in global HIV. Nobody was, but the CIA was. They were saying that the magnitude of this epidemic was going to destabilize militaries, whole economies, whole societies, and they were arguing for that. So there are lots of reasons to get involved in global health, and practically it's become more possible to become involved in global health. The Bill and Melinda Gates Foundation has spent $10 billion over the past year, and this past 7 years. And this article and the graph here talks about what, as you can see, is entitled the Gates-Buffett effect. This money has actually catalyzed a great deal more from other public-private partnerships and also government agencies. Pretty amazing to know that the money for global health, even in these very difficult economic times, has quadrupled since 1990 from about $5 billion to almost $22 billion. So there's a lot of money being spent to try to address global health challenges, including HIV/AIDS, but certainly lots of other ones also. And I would argue that it's very important that there are people that know how to spend that money responsibly. About 30% of the money is coming from private donors, so it doesn't necessarily have a whole lot of oversight. And I think that the leadership in global health needs to be very careful about thinking about how we can have the most impact. In addition, we've got a whole lot of people interested, a lot of people care, there's money to do something, and therefore there are jobs. And on a university campus, this makes a big difference for us. I see there's probably some students in the audience. When I was graduating from college in 1993, there weren't jobs in global health. Now, over how many years is that? I'm coming up on 20 years later. There are lots of jobs in global health, and providing the training that our students need to be able to provide the leadership to address these complex issues is something that we're really interested in here at UVA and at the Center for Global Health. There was a survey performed by a group of universities interested in global health this year, and in the past 3 years, the number of undergraduates and graduates that are participating in global health programs has doubled, and that's just continuing. I know that here at UVA in our Global Public Health minor, we have to turn away well over half of the people that apply because it's such a popular area of study at this point. So this is the, I had to put this slide in, the Consortium of Universities for Global Health is a group of universities led by some familiar names, University of Washington, BU, Hopkins, Emory, and Duke, as well as UVA. I'm very proud to say that President Castine signed on to the statement put together by the Consortium of Universities for Global Health, indicating that we as universities can and should be organizing our resources to provide integrated responses to the complex health needs of a region or country. So this conference that brought these universities together actually occurred last month, but I would like to point out to you that UVA has been really at the forefront of global health for decades, and that it really fits with many of the values that have been a part of this university since its founding. So in order to just sort of give us a summary of what is global health, I argued that it's not really just global disease like H1N1. That's certainly a part of it, but that's not the only thing. Global health, then, is an area for study, research, and practice that places a priority on improving health and achieving equity in health for all people worldwide. So not simply focusing on the health of our own populations or simply focusing on the populations in resource-limited settings, but looking for equity in health worldwide so that all people are able to achieve their full potential. Global health emphasizes transnational health issues, determinants, and solutions, a multinational approach to solving these problems, not just a bi-national or single nation addressing these problems, involves many disciplines within and beyond the health sciences, and promotes interdisciplinary collaboration, something that universities should really be excellent at, and is a synthesis of population-based prevention with individual-level clinical care. And that's in contrast to public health. Certainly, again, not to denigrate public health, but public health focuses more on a population level. When we're talking about who's going to get the swine flu vaccine, you have to talk on a very broad level. You say pregnant women have to get it. But then how do you look someone in the face that's come to your office to say, I really want the H1N1 vaccine? There are difficult trade-offs that are made in public health that are hard. And in global health, we don't say to the Joseph Jean, you know what, it's not appropriate for us to give you expensive medicines. Instead, we say, we need to figure out a way to make the medicines less expensive so that we can provide them for everyone. So it's a subtle difference, but important. So these next slides are some real giants at UVA who have been involved in global health for decades. So Dr. William Parson, I'm not sure if anybody knew Dr. Parson. He was the chief of medicine in the late 50s and early 60s, and was a really, I wish I could have met him. He played a concert at Carnegie Hall at 16. He taught a course here at UVA in the English department on Dante's Inferno. He apparently hated slides, so he'd be very disappointed in me and would probably hate PowerPoint. But he was also a really very talented endocrinologist and physician who ended up moving from UVA to Kampala, Uganda, to become the chief of medicine at Makerere University, which is often called the Harvard of Africa, particularly before it was decimated by Idi Amin, and that was when he was there. And as you can see from his quote there, he felt strongly that it was an important imperative of his to get out of the comfort of UVA and go to what Dr. Garant likes to call the real world, where he could really make a difference. And he, while there, was instrumental in training dozens of African physicians who still remember him, and we're very proud to have welcomed the current chief of medicine at Makerere University here at UVA 2 times in the past 3 years, a wonderful woman who remembers Dr. Parson from when she was a student. So he was one of the first. Another, Dr. Thomas Hunter, I don't know if any of you know or knew Dr. Hunter, really a leader also who provided this important perspective, I think, on what our role should be relative to health. But he didn't travel as much. He had suffered from polio as a child. He was the dean of the School of Medicine in the late 50s and early 60s, a contemporary of Dr. Parson. And what he did was to formalize and structure the training of physicians from resource-limited settings by physicians from the United States. So he really focused on training, improving the access to health care in resource-limited settings by improving the access to physicians. And that was part of the question that someone asked also, and I'll come back to it, but I think that UVA has long been a key part of trying to prevent or reverse that brain drain by helping to train physicians to work within their own context and care for their own populations. So that was Dr. Hunter. I'll mention that Dr. Hunter was also responsible for Dr. Richard Garant's first airplane trip to the Congo right after he was married. So there's this lineage here. And Dr. Ed Hook, did anybody know Ed Hook? Was the chair of medicine. And he was the first to really develop bidirectional research collaborations particularly in Brazil, and I think that that is another piece. In addition to the training of international physicians, there's also been the development of really creative international research collaborations that create knowledge that can address the issues faced in these poor countries. So this is Dick Garant in a variety of settings in Brazil and here in Africa. Many of you may know him. He started the Center for Global Health in 2000. That was after he'd been involved in a collaboration in Brazil for over 30 years. And his work has led to the Center for Global Health with this mission. The University of Virginia's Center for Global Health promotes health in resource-limited settings by fostering the commitment of students, faculty, and partners from many disciplines to address the diseases of poverty. We have sponsored the work of many students, as you can see, both students from around grounds as well as medical students. And these bars represent the number of students that we have provided scholarships to go and do global health projects. We also support the professional development of junior faculty member from our partner universities. These three, Sami Amadou, Edgar Musi, and Lafuna Mavandu, are all from the University of Venda. M. Savilleja is from Manila, the Philippines, and also participates in one of the UVA choirs. These have all come to UVA to advance their careers and then gone back to continue their important work in their home countries. These are the sustained collaborations that UVA has between a whole variety of countries and universities: Brazil, Ghana, Uganda, China, Philippines, Bangladesh, South Africa, Tanzania, and Haiti. You can see that we've been able to involve a lot of UVA students in these collaborations, as well as inviting fellows here to advance their training to better prepare them to address the challenges in their own countries. So in addition to the people, and I believe that the people are really probably the most important thing. I wouldn't have thought that initially, but really, once you get down to it, being able to train individuals who can go back and make a difference, I think, is one of the most important impacts that we can have as a university, both our own students and then people from our partner institutions. But certainly another thing that universities are able to do, and we're proud to be involved with, is developing new knowledge. And this gentleman, Dr. Lee, actually unfortunately died several years ago of a brain aneurysm, but had been the Secretary General of the World Health Organization, and he defined what I think is an important concept, the no K-N-O-W do gap. And that gap is between what are our scientific advances and whether or not we're able to apply them. And he argues that that's what should really be a focus of our work in global health, is how do we take what we know and actually make sure that it helps the people who need it. A great example is insecticide-treated bed nets. So insecticide-treated bed nets are one of the best strategies to decrease child mortality worldwide. And yet only about 10% of the people that need bed nets have them. And they really shouldn't be that hard to get to people. But apparently they are, and we need perhaps to get out of our own medical schools and start asking the commerce school people, okay, or the engineers, what we need to do to develop a supply chain that could get these insecticide-treated bed nets out to the kids who need it. So just wanted to provide a couple of examples of important research that's been done at this Center for Global Health to both measure problems and to help define their solutions. This is a slide that summarizes some of the 30 years of work that Dr. Garant has done to define the problem of having diarrhea. Now, diarrhea is never something that we like to talk about, particularly not around mealtime, but it's a fact of life for a majority of the children in resource-limited settings, so much so that I'm often surprised that when I go and ask people whether diarrhea is a problem, they'll say no. And I say, but how could that be when diarrhea is the leading cause of death in children under 5? And many people tell me that, well, why would we go to the doctor for that? It happens every week. So diarrhea really is, unfortunately, a fact of life, usually caused by contaminated water or food. And while people accept it as a fact of life, it has very serious consequences, including growth shortfalls. So HAZ2 is the height for age z-score at age 2. And it is estimated that by age 2, about 3 centimeters have been lost, so that's about an inch. By age 7, about 8 centimeters, or coming up on 3 inches, have been lost in kids that have suffered from multiple episodes of diarrhea as children. So, okay, it's not terrible to be short. I'm the shortest member of my family. But unfortunately, it's also an indicator of other kinds of growth that have not occurred, including cognitive growth. Particularly in the children under age 2, repeated episodes of diarrhea have very severe consequences for brain development. And I think that that's one of the greatest tragedies when we're robbing people of their ability to achieve their full potential from the very beginning because of the dirty water that they're consuming. So Dick and Dr. Bill Petrie, also in the Division of Infectious Disease and International Health, have actually been very successful at convincing the Gates Foundation to the tune of $30 million that this is a really important problem. And they are now leading an 8-country study to try to really define what might be strategies to break this cycle of diarrhea, malnutrition, and ultimately often death, or perhaps worse, morbidity, meaning loss of growth, loss of cognitive ability, loss of quality of life. And so we're very excited about this study, which is starting, again, as I said, in 8 countries, including 2 in Africa and 4 in Asia and 2 in South America, to help define this problem and to develop solutions. Another example of trying to bridge this no-do gap is led by Dr. Chris Moore, who works in Uganda in the same hospital where Dr. Parson was chair of medicine, as well as another regional hospital. Sepsis is caused by bacteria in the blood, usually, a leading cause of death in hospitals in sub-Saharan Africa, and often not managed very well, despite the fact that we know exactly how to manage it here in the United States. And what Chris has done through a very innovative research program and also training program of physicians and also nurses and care assistants is to develop strategies that are appropriate for Africa to manage sepsis and to actually save the lives of those people coming into the hospitals. And we're very proud of the work that Chris has done. In Haiti, this is actually in Port-au-Prince, Haiti. These are my colleagues there. We are working on a problem that I think is pretty horrifying to all of us who are parents and probably to everyone. This is a curve that shows what happens to babies born to HIV-positive moms. So we're very fortunate in Haiti to be able to prevent the transmission of HIV from mothers to children. But unfortunately, we're still seeing that they do fine up to about 6 months, and then they drop off. What do you think? What happens at 6 months to kids? They get weaned. Yep, exactly. So these kids are getting weaned off of the formula that's provided by the government, and they immediately drop off, and unfortunately about 10% of them die. So the problem that we were faced with was, what could we provide as a weaning food that would be feasible in Haiti, very poor country, and that would hopefully prevent the drop in growth and also, of course, the mortality that we were seeing. And these are 2 nurses that are leading the project that provides actually peanut butter. Now, most of us in this country shudder when we think of providing peanut butter to kids under a year old. When we because of the issues of peanut allergy. Now, when I brought up peanut allergy in Haiti, all the pediatricians looked at me like I was completely crazy. Peanut allergy, we have discovered, is not a problem there. Peanuts are grown in Haiti. Peanut butter is a staple there. And peanut butter has a lot of wonderful qualities, despite our horrible experience this last year with our Virginia-based company that had the salmonella-contaminated peanut butter, unfortunately. Usually, peanut butter does not grow bacteria well because the moisture content is very low. So it actually is a really good food to use to try to feed babies, because it generally has very high levels of calories, fat, other things that they need, and very low levels of bacteria. It's easy to store, it's palatable, and in fact, despite the fears about peanut butter in this country, the project has worked remarkably well with the kids suffering far less diarrhea, growing better, and not having any mortality due to diarrhea in this peanut-based feeding strategy that we've tried out in Haiti. So we're very pleased about that and are particularly pleased because it's provided work for Haitians who are growing peanuts and making the peanut butter locally. So while we're excited about all of those projects that have solved problems or have described problems or solved problems that are disease-based, diarrhea and sepsis, we wanted to push ourselves to really fulfill the full potential, to really challenge ourselves to meet the full challenge of what global health's definition is today, including the multidisciplinary aspect of it, including the collaborative nature with our true collaboration with our partners, including both an individual and a population level approach. And thanks to a long history of collaboration in this region of South Africa, northeast region of South Africa, very rural, former homeland, meaning sort of like a Native American reservation under apartheid. They were able to maintain their traditional leadership structure, which protected them in some sense, but also meant that they never got any of the development that the rest of South Africa enjoys, including roads, schools, etc. They have been struggling since the end of apartheid, struggling successfully to develop that kind of infrastructure that they did not have. UVA has been involved with this region for decades through environmental sciences with Hank Shugart and Bob Swap as the leads there. And while Hank and Bob have done terrific work on climate change and et cetera, their partners at the University of Venda, which is located here in Thohoyandou, also mentioned that in addition to thinking about climate and environment, we really needed to think about health. And so Bob and Hank invited Dick Grant and myself to go there and think about what might be a health project that we could get involved with that was relevant to the people in this region. And overwhelmingly, it was felt that health issue was water and the diseases that it can entrain when it's dirty. So we've been very fortunate with generous support from the Jefferson Trust, run out of this building in the alumni office, as well as from an alumna in California, to be able to launch on a 5-year project to work with 2 communities to assess their water supply and their health outcomes and to develop strategies to improve it. This is a collaborative project of the School of Medicine, School of Nursing, School of Engineering, School of Architecture, and School of Education, as well as Arts and Sciences. So we're very proud to be able to bring everybody together to work on this project. It hasn't always been easy. We've often found as faculty members that we'll be sitting in a room talking to each other and using the exact same words, and then all of a sudden we realize that we mean completely different things. So even the communication on our own side is sometimes complicated. But I would have to say that I get to do a lot of exciting things, including taking care of my 2 beautiful children. But this is my most favorite project right now because of those challenges, and I think because of the potential for real change. So we have, I showed that picture of the fellows. 3 of them were from the University of Venda, and many of them have documented that there's terribly poor water quality in Limpopo province. Most people are collecting water from surface sources like this one. As you can see, if you're drinking out of the same water that you're washing your clothes in, etc., not optimal. And many of the children suffer from diarrhea. It's unfortunately the 2nd leading cause of death in Limpopo province following HIV/AIDS. Unfortunately, the problem is getting worse, not better. Since 2004, the rates of diarrhea in children have increased 170%, and the rates are 2 times higher than anywhere else in South Africa. So it's a big problem according to South African statistics, and here you can see those causes of death. So our challenge was to engage students, faculty, and other partners at UVA and at the University of Venda or UniVen to create innovative solutions to ensure access to water and sanitation and to improve water-related health outcomes in Limpopo province. So how do we do that? Well, this is a very busy slide, and I think it represents sort of hopefully the promise, but also the challenge of global health. So with the University of Virginia and the University of Venda, we involved a variety of different disciplines and a variety of different strategies, student projects, summer study abroad, faculty mentors, and researchers to begin to address this problem. And our goal is to take what have been in the past individual projects of students and faculty members that are by nature small. We have our own funding streams that require us to have clear hypotheses that have, specific aim number 1, 2, 3, and this is how we're going to address it, and this is going to be our outcome. We wanted to go from projects to a program that could really lead to improving access to water and health in Limpopo. So a program that could hopefully seamlessly, but not in reality completely seamlessly, integrate the knowledge and the practice of physicians, of nurses, of engineers, of planners into a solution that would provide a measurable change in access to the amount of water and hopefully also the incidence of health problems in the communities that we're working with in Limpopo. So to start off, we worked together, we brought together a workshop. Here's Bob Swap, one of the original leaders of the partnership in that region, as well as the group that came together as a workshop. So faculty members and students from UVA and from the University of Venda, as well as community members who came together to discuss how we could begin to approach this. This was about 1.5 years ago, and you may recognize some of the faculty members: Garrick Louis here from Systems Engineering, Nisha Bochwe from Planning, myself from Medicine, Jerry Learmonth from Systems Engineering. And it was a tremendously helpful process to hash out together what our questions were going to be and what our approach was going to be. And even better, once we got out to the communities to speak, for example, to this woman who's the chief of one of the communities that we work with and who welcomed us in her home and underlined the importance of water to her community, and the fears that she had that without water her community was going to disintegrate. So in addition to meeting with the chief, we met with a women's group, we heard from the elders, we visited what sanitation is available, and we took some walks up the hills to understand what the children were doing for water in schools. In fact, one of the schools had decided to purchase a swimming pool filter to try to clean their water, which wasn't working very well when we actually tested the water. And we really came to understand that particularly the children were at terrible risk in these group environments for drinking contaminated water. The solution of the communities have been to pipe water down. They had actually purchased PVC pipes and had dragged them up of the mountain about 5 kilometers into what they felt was the cleanest stream, put them there, and then allowed gravity to bring the water down through these pipes to their villages. Unfortunately, the pipes were frequently broken, and it doesn't come out very well, but this is the pool where they're actually pulling, from which they're pulling water, and you may see that there's a fair bit of slime. It's probably not the technical term for on top of the water, which my water colleagues tell me is not indicative of very clean water. So as we started looking at this, the engineers immediately began to think about gravity and how we might build tanks that could hold more water and that could provide a better quality of water. But our planners said, hold on, let's think for a second what's actually going to be sustainable and possible. And one of the things that they suggested was that we ask the community what they thought. And one of the ways that we were able to ask the community that question was by asking them to take photos of what they felt was most important about water in their community. And this is a methodology called photo voice, and I see that I'm out of time, so I'm not going to say a whole lot more about this, but it was the strategy to really involve the community in telling us what the problem was before we came in with a solution. And some of the pictures, I hope some of you may have been able to see our exhibit at Newcomb Hall of the pictures that were taken by the participants, but the participants told us a lot. They told us, first of all, that health was not their biggest concern, that access to more water was their biggest concern. They did show us that, including dead animals in their water collection area, that their water was contaminated, and that it was also incredibly precious. This photo has always sort of tugged at me because I see the state of this young man's clothes, and yet the incredible care that he's taking to water one by one his cabbages for sale. So it speaks to me of the precious nature of water. In order to try to follow up on what the community told us about their need for more water, we had 11 students over there this summer. This is Patrick Upchurch from the medical school working with a University of Venda student doing water quality testing. These are University of Venda nursing students that are measuring children, helping filter water, and also taking GPS coordinates so that we can map the villages appropriately. This is all part of the assessment process to be able to understand how much water people have, how much water people need, and what the effect of the dirty water is. The students produced incredible maps like these and are now enrolled in classes with our faculty mentors to be able to design the prototype water systems for next year that we'll be able to implement with the communities and with our partner students and faculty members at the University of Venda. So it's difficult to encapsulate a solution to a global health challenge like dirty water, and I think that's part of the point. I believe that universities are probably probably the only organization that can bring together that range of expertise to try to address that problem. And I think that we also have a responsibility to our students to provide that kind of experience so that they can become involved later in addressing these challenges. And even our founder had a comment, of course, about health being worth more than learning. Certainly learning is difficult without health, and I am proud to say that I believe that here at the University of Virginia we continue to be on the forefront of global health. And if you'd like to learn more about that, we're having a symposium on the 6th of November in Jordan Hall Conference Center with Dr. Tom Quinn, who's a true expert in this field and a very compelling speaker. I'd invite you all to attend. There's no need for pre-registration. And thank you, Rolavua and Chivenda, the language that is spoken in the region we work in South Africa. And I'd be happy to take any questions.
Many years ago, the Institute of Nutrition for Central America in Panama had developed a relatively low-cost and effective weaning food. One name is Incaparina. The peanut butter, the peanut comment jogged my memory on that. Is that still around, or is anything done with that?
I'm not aware of that one. What was the base of it?
Actually, I don't remember how it started out, but it was done through Nevin Scrimshaw at MIT.
Yep.
And they developed a number of different formulas depending on what the native grains and legumes were.
Right, right. Certainly Dr. Scrimshaw's work is still so influential. He was one of the first to really define the relationship between infection and malnutrition and the importance of not only calories but also making sure that children are getting clean food and water. I'm not aware of that specific name, but certainly there are different formulas based on what is available in particular regions. I know that the peanut-based formulas have been very successful in areas where people eat peanuts, like sub-Saharan Africa, Haiti, have not been as successful in South Asia, and there's been a lot of controversy about that, actually, because they don't seem to be as palatable or as acceptable in South Asia, which actually has the largest problem with malnutrition.
Thank you.
Yeah.
Can you tell me what the university is doing with regard to Lyme disease? This is a problem, becoming a big problem. People are going to Pennsylvania and New York to get help.
Right.
Here don't seem to be recognized or test for it.
I think that's a really excellent question, and if I could just speak on the global health side for a moment in terms of multidisciplinarity. I think that in addition to medicine, we need to get our entomologists involved, et cetera. So the Lyme disease problem has been skyrocketing over the past 3 to 4 years. The testing, for example, when I arrived here in 1999, suggested that Lyme disease did not exist in our tick populations in Virginia. That has changed drastically in the past 10 years, and no one honestly has been able to explain to me what's changed in terms of deer, in terms of white-footed mice, in terms of the ticks, but it's quite clear that Lyme disease is being transmitted endemically, so in our region now. We used to see it in people who had traveled to the Northeast, who had even, it was as close to us as Maryland, but it hadn't been really here, but it's clearly now here. In terms of a coordinated response to Lyme disease, certainly we're seeing it regularly in our clinics now, and working to help the people who are suffering from it. I will say as a practitioner that the science is quite fuzzy in terms of what is the right thing to do about people who have long-term problems from Lyme disease. I think that the challenge has been many people in the Northeast have received months and months of intravenous antibiotics. And for some people that has worked. It's not been clearly proven to solve the problem, and in many cases has resulted in more problems from infections associated with the long-term catheters that are required, particularly in this age of methicillin-resistant Staph aureus, which is a very common contaminant of that kind of catheter. We're very hesitant to subject people to that without clear evidence of benefit. Another important side effect that can occur from long-term administration of those kinds of broad-spectrum antibiotics that are effective against Lyme disease is Clostridium difficile. I imagine many of you have heard of that. It's an antibiotic-associated diarrhea, which can be really devastating and even fatal, and is associated with that kind of long-term administration of antibiotics. So I think that is a sort of a roundabout answer. I would say we're certainly seeing and treating it in our infectious disease clinic now. The question of what to do about chronic Lyme disease, I believe, is an open question, and I will tell you personally, as a practitioner, that I am often very hesitant to start long-term intravenous antibiotics for the reasons that I just mentioned, because I don't feel that the cost-benefit analysis has been worked out yet. Oral antibiotics in certain situations are acceptable. The tetracyclines like doxycycline that is effective can be very helpful, but again, they do have important side effects. I would say that I think that this is a rapidly evolving situation, and that more will be done. The National Society of Infectious Disease Physicians is working on it. Many people are trying to determine what it is, if it's not actual infection with the bug that is causing the suffering that people are experiencing following infection with Lyme disease. There's no question in my mind that people are suffering. Whether it is from a germ actually replicating that an antibiotic is going to affect, that's not clear to me yet. Thanks.
Dealing with the cultural aspect, what has been done in some of these programs as far as integrating witch doctors because of the power structure that exists there, and educating them and providing the inroads to villages and healthcare, and then also what is being done as far as the latrine construction training, which often can be done at a resident facility like a hospital.
Those are great questions. Okay, so the first question was about what are we doing to integrate traditional healers into our strategies to manage these complex health problems. And the second question was, what about the building of latrines and training in building latrines that can be done from the clinical setting? So in answer to the first question, great question. We're particularly well, actually, both in Haiti and South Africa, we're very lucky to have close collaboration of traditional healers. Traditional healers have attended trainings with our physicians, nurses, and other practitioners to learn about the signs and symptoms of HIV and TB and to talk about the way they manage it and times at which they would feel it was appropriate to refer. And it's been a very successful program. Certainly traditional healers are very effective at dealing with a wide variety of problems that Western healers are not, including a lot of mental health issues and also chronic pain. And so the traditional healers have maintained their role there, but have started to refer, because care is available, those patients that they know they can't cure with TB and HIV. Certainly that's not accepted across the board, but they really have bought into that sort of separation of responsibility now that there is effective therapy available. And again, that's in one particular setting in Haiti. It's not across the board, but I've been very, very impressed with their eagerness to become involved in that process. One of the pictures, actually, of one of the fellows from South Africa showed him with a lot of plants spread out. And in South Africa, there's been a lot of controversy about how to treat HIV, and traditional plants have been a real question. And he's done an excellent job of working with traditional healers to identify the plants that they have used and to actually study them in relation to their ability to combat not as much HIV as the opportunistic infections that often attack those who are infected with HIV. So I believe it's a really important aspect of addressing particularly HIV/AIDS, but certainly other global health challenges as well. Traditional healers are an important part of any response. In regards to the latrine training, we have not started that yet in South Africa as part of our project. One of the challenges has been that South Africa has one of the widest disparities of wealth in the whole world, right up there with Brazil. And the people in the communities we work with really want flush toilets. And in a water-scarce area, I've been learning a lot about how wasteful flush toilets are. And so we've been working with the community to try to make latrines or composting toilets more appealing so that that's actually something that is desired. And we're hoping to install a composting toilet this summer in one of the chief's crawls to be able to demonstrate that that's something that is actually not a second-tier solution in a place that is struggling so much for water. I don't know if anybody saw, I think it was last week in the Washington Post, that there's a big campaign in India now that in order to get a bride, you have to have a latrine. So apparently that's been terribly successful, and I hope it takes flight and travels to some other countries, because that's a great strategy. I have time for one more question.
Quick question. With your organization, your global health, are you incorporating other NPOs and trying to network in those directions?
We're always open to that. We've worked with Partners in Health, Physicians for Peace, Operation Smile, and also Bridges to Community, Potters for Peace. So we're trying to work with all of those organizations and find ways that we can help to facilitate the questions that they want to answer, whether they're evaluative questions or research questions. All right, thank you very much. Enjoy the game. Go Hoos.